had a chance to read it. I'm just going to very briefly summarize, and hopefully Dr. Breidenbach will give further details regarding his career. But he's coming to us presently from the University of Arizona. But notably, in 1995, Dr. Breidenbach initiated the first program in the U.S. and also the world at the time to perform hand transplants. This led to the first successful hand transplant in the world in 1999. Over a span of 12 years, Dr. Breidenbach transplanted 6 patients and 7 hands at the Kleintert-Klutz Institute, I believe, which holds the distinction of the only private hand surgery practice performing hand transplants. His pioneering efforts led to a paradigm shift in reconstructive surgery that resulted in the foundation of a new field of vascularized composite allotransplantation. Pardon me. He's the founding president of the Hand and Composite Tissue Allotransplantation Society and the American Society for Reconstructive Transplantation, and the India Hand Society in 2007 made him honorary professor of hand surgery. Today, he will speak to us on a statistical comparative assessment of face and hand transplantation outcomes to determine if either meet the standard of care threshold. Dr. Breidenbach.
Thank you, everybody. It's my pleasure to be here. And I hope this will be a lecture you'll never forget. What I'm here to tell you about, most people in the world do not believe will happen. I'm going to start with a small prediction. Let's see if I can make this work. That's out. So I live in Tucson, Arizona now. I was 27 years in Louisville. I've lived in Munich, Montreal, Paris, Calgary, and all over the place through my career. It was normally that I was running from one to the next. The bio is much more romantic than reality, and I'll get into reality in a second. This is right out of my front window. Actually, if you want to see God talking to you, come to Tucson in the morning or the evening. There was an eclipse of the moon or the sun, or someone was eclipsing somebody. But anyway, the whole moon turns red when that takes place. So there's another side to this story of where I come from and what's taken place. I was told I went to a prestigious Eastern college and was told that I'd never be a physician, that my grades weren't good enough, I wouldn't get to Harvard. My father went to Harvard, my father's father went to Harvard. So to move on and find something else to do. I was refused to 30 medical schools. These are the type of things you can't put into your bio because your enemies will use it. But that's the reality. Life's a bumpy, tough course at times. That's me entering my fellowship years in the 80s. And that's my son. I have an unusual family structure. I have a son who I adopted. I was never married to his mother. I raised him as my son. I have an out of wedlock, and then I got married and have this little boy who's now 4 years old. My wife followed a very similar course to mine. She came from what had been a relatively well-off family in Poland during communism, but then got crushed. I mean, switching to capitalism was very difficult. I better get track of time or I'll end up. She ended up moving to Paris. Her dream was to become, a Versace model, but she was pretty headstrong. She's a narcissist like myself, so we have some interesting discussions at home. My son I had no choice in this, was baptized in Poland because, as I said, my wife's Polish, and the international meeting was there, and the godfather of my son and mother are members of the Polish team that did the hand transplant. So this is all very incestuous. It happened very suddenly too. we were at the meeting, and I knew the Polish team, but I got to know them very well, and so we just popped the question to them on like a Thursday, would you mind helping us baptize our son? So he's truly Polish. He was a little suspect about what was going on as we walked forward. So, vascularized composite tissue allotransplantation. The conventional wisdom is that this is just like some little drop in the bucket, irrelevant, kind of an interesting. It is going to revolutionize solid organ transplantation. It will replace solid organ transplantation as the most commonly done transplant. If you don't see this and prepare for it, you will be wiped out by it. The chances of what I'm saying taking place, I give at least 50% chance within the next 5 years, certainly by 10 years. It will not come through mixed allogenic chimerism and David Sachs and Susan Ilstadt. It's going to come before what's right in front of your nose. And so I know, I hear it all the time, well, he's going to talk about a hand transplant, but it's a one-off, it means nothing, it's not. Listen carefully to what I'm telling you and remember it. Now, remember I also said 50-50. The immune system always figures out a way to humble you. How do we get here? Where are we now? What are the present problems and what's the future? Part one, how do we get here? Bernard Shaw said, all great truths begin as blasphemies. And it was a blasphemy to say that you could transplant a hand. It was considered impossible. And the reason it was considered impossible was that the skin was felt to be way too allogenic to be able to sounds the same, right? Or is it not on?
It may have turned itself off. Test.
It's okay. You can all hear me pretty well. My wife says my voice carries everywhere. And so the skin has always been felt to be the target and the problem. And that's conventional wisdom, and no one disagrees with that except for me and a few other people. I don't believe that skin is the target. So blasphemy number one, skin is not the target of rejection in composite tissue allotransplantation. Skin is a strong allogenic barrier, is the conventional wisdom. And if you use routine immunosuppression in order to try to transplant a hand and keep the skin viable, then what's going to happen is that it will reject. And if you try to raise the immunosuppression to avoid the rejection, you may be able to raise immunosuppression high enough to stop skin rejection, but then the patient dies. So it was the rock in the hard place. There were over 300 publications on small animal models and some large animal models, and all of them failed. All of them. Now, what was interesting is I was a resident at that time at McGill under Roland Daniels and Julia Terzis, and those don't mean much to you in the transplant world, but they were the godmother and godfather of reconstructive microsurgery. Roland Daniel did the first free tissue transfer when he was like 33 and became head of the department, jumping over a bunch of people, causing total havoc at McGill politically. But I wandered into that milieu and became interested in what Roland Daniel was doing. I'm going to jump ahead and we'll catch up in these slides. He was transplanting hands on non-human primates. And it worked. The trouble was, at 6 months and 8 months, the animals started dying from tumors, PTLD, infection, because the immunosuppression load to keep the hand on was 4 times higher than the immunosuppression load to keep a kidney in a human. So it was about 1,000 nanograms per mil is what you had to run it at, or 1,200 nanograms. So once again, that got condensed to the statement that that skin was the target, because that's why the non-human primates needed such a large amount of immunosuppression. Now here's your first question of the morning. I won't point fingers, but I'll see. And so I've been, listen, we did this, we transplanted in '99. I've been giving this lecture for many years. Only one person ever got it. So non-human primates will run at 1,000 to 1,200 nanograms per mil to keep the hand on, whereas to put a kidney in is going to be 250 of cyclosporin, something along that line. Why? And the conventional wisdom was it was the skin why you needed to run it so high in the non-human primate. Is there another diagnosis as to why that would take place? This is your Nobel Prize moment. Marrow's a good guess. So for the next, from 1981 or 2 until 1999, no one answered that question. And here's how simple it was. Non-human primates metabolize cyclosporin and FK differently than a pig. That's simple. I was right there looking at it. I could have had a 20-year start on my career. But I walked away from composite tissue at that point saying, well, it's just never going to work. The skin is too much. And the whole world did that. So the thing you need to think about is, look how we think as humans and how we miss, what's actually happening. And this never gets written in the textbooks. When I do my book, it's going to be that way, but okay. Principle number 2 is, if you're trying to figure out a problem and sort it out, particularly in immunology, but in business and everything else, you have to realize conventional wisdom is very strong and will push against you. There are whole societies built to push against you. And so as Bernard Shaw said, reasonable men conform to the rules of society. Unreasonable men try to conform the rules of society to them. That's why all advances are made by unreasonable men. The American Society for Surgery of the Hand was not a happy camper when we did the first hand transplant in 1999. They went after my medical license. They wrote articles in the New England Journal of Medicine saying that I had violated patient rights, I was going to kill the patient, so on and so forth. And then they never forgave me when it worked. That's just the way life is. 1995, we started, in 1995, we decided to start a program purely by accident. What happened was the university and the private hospital, which worked together, wanted to do a revolutionary project. And I brought them the idea of hand transplant because I'd seen it talked about at one of the meetings. And they were doing it on rats, and I thought it was kind of cool. But I said, look, I don't want to do this. I was a peripheral nerve surgeon, and my interests had gone, my work had gone for 10 years. And they said, well, we got $400,000 we'll put into this. Move forward. I said, I can't. It's not. I had a biochemistry background. I had a master's degree, but I just didn't feel that's where I wanted to be, and I didn't think it would work. So they went around the country. They tried to get Adriana Zeeby in Pittsburgh. They tried to get Ewan Black around California. But no one would take the $400,000 and move. So they gave it to me. They said, go do something with this. This is what we want. Well, in 1995, I started the project with the full concept that would still be working on it probably till the end of my career. Within 5 years, we've done that. And it just goes to show you, I mean, I'm glad I took the project and took the money, but it was a close call because I hadn't really read any technology for years, so I started staying up in my reading of technology. I will say one thing, I love science. I enjoy reading immunology, economics, and history. My wife wants to kill me when I'm on vacation at the beach because she can't understand why I'm sitting there reading a book on immunology. But to me, it's like watching God work. So we now come to really a critical philosophic concept which influences medicine. So we put together a team. I put together a team and everyone had assignments. And interestingly, a lot of people signed on. I thought it was an exciting project, something that had never been done, probably couldn't be done. And in those days, So I insisted that we read everything in the literature that we could before we initiated spending any money or doing anything. We spent almost 2 years reviewing literature, calling people, speaking to people. So I'm going to jump to my brother and myself and then come right back to this. Now, my brother and I had philosophic differences. He went to Groton and undergraduate and was accepted at Harvard, Yale, Princeton, went to Stanford on scholarships, and never did anything in life. You'll get the picture of the philosopher. And we used to talk about I'm not picking on philosopher, but he really was a philosopher who wanted to do nothing. He was like, and so I asked my brother once, what's your goal in life? And he said, well, I want to be able to take a rock, I want to drop it, and I want to have it fall into heaven. This is critical. There'll be no reason for that. What are you talking about? And I said, for me, I want to be successful, famous, or an all-star, whatever, something much more conventional. Well, the rock analogy got me thinking a lot over the lifetime about something that he had said was true and also not true. So and this will be the question to you. So if I had that rock and I dropped it and you went into heaven, and then I put a phone in front of you, who would be the next person you would call? It's a tough question, kind of shunting. But I know exactly who would be that. It took me a long time to understand. It would be the patent office, or it would be Boeing, to tell them how we can get a rock to the other side of the world without expending any fuel. My point is that when the rock drops into heaven in front of your eyes, figure out what's going on. Just don't say it doesn't work, it's impossible. And N of 1 is the most significant leading indicator in science. You can't sell it immediately, but you better follow it along. So when we looked at 300 articles reviewing the literature over a couple of years, we found one paper that successfully transplanted rat hind limbs onto the rat using cyclosporin, but also a new drug called MMF, mycophenolate seems standard now, but it just, in the early 90s, and it kind of got approved in 95, right as we were starting. And when you put those two drugs together, you could successfully transplant it on a rat. But no, we as humans do very poor statistical analysis. We see 299 papers published by world leaders that it doesn't work, and one paper saying it does work, and we focus on the 299 as though it's a weight, and it isn't. It's the rock dropping into heaven right in front of you, asking for an explanation. So we called a team, it was at UC San Francisco, and then we started working in the same area. And basically, well, read all the literature, that's number one. That's so much easier to do today. I mean, you forget how difficult it was in those days. We didn't have flow of information that was the same. So in the process of doing this review of the literature, when we discovered that article, we started working on a small animal model, then went to the pig and the large animal. But what also came out, which is totally shocking, is that every single tissue in the hand had already been transplanted. Transplanted. Now, bone and joint had been done in Germany by Hoffman in '96. He transplanted the knee, femur-knee combination. It was in German. I went to university in Germany, so I spoke German. I found the article, but we didn't have that flow of information. Nerve had been transplanted by Susan McKinnon, who's at WashU, and that had been published, but she would take the nerve out and she'd leave it in a petri dish for a week in solutions. It didn't quite fit the transplant model, and the results weren't good, but it was done. And then tendon had been done by Gimberto, vascularized. He took tendons from brain-dead donors and put them into patients, and it worked. But none of this seemed to sink in or get through. Muscle had been done with a patient who had had a heart transplant, got a huge squamous cell, and they used a rectus muscle from a brain-dead donor to cover it. using the immunosuppression that was already present. And here's the one I love the most. We got an unpublished look on a paper developed by Wynn. And what he did is he was, I believe he's a transplant surgeon. He's in California and he's still practicing. He took skin off the living-related donor who was giving a kidney. And when the kidney went into the recipient, he put the skin graft on the patient. He did 2 or 3 patients that way. Actually, he did 6. And when the kidney rejected, the skin graft rejected. And if the kidney wasn't rejecting, the skin graft did fine. So now, we had a small animal model. We had all the different tissues done kind of combinations. And we hadn't even started doing anything. And it was all in the literature, all right in front of our eyes, and we had been told by the world that this was impossible. So, everything had already been transplanted before the first transplant, so it doesn't really seem that we did that much, if you think about it. We actually read the literature carefully and took a long time doing it. Now, these are the people who did the non-human primate studies. This is all published, and you look at it. It was in Pittsburgh, where Stark was, Hovius was the Netherlands, and Roland Daniels was my chief. And see a little S on the side, that's a mistake. And those are the differences. We've already talked about that. So my principle number 1 out of all this is that skin is not the target. Now, most people still disagree with that, but I think the evidence is really clear. And from what I've already told you, you can kind of see that. And it gets, again, to a principle to keep in mind that really discovery is seen what no one else sees. It's what everyone sees but doesn't think. And that's the question that I had already asked you, so I'll skip through this. But no one ever gets it. I don't know why it seems so fundamental. I didn't get it. As I said, it held me up for years. So when we started the project, we went to the pigs. We got this information. We were still believing that skin was the problem and that we couldn't use high levels of immunosuppression and would have to, because we were still working off the non-human primate model. So we started with local perfusion, and it was a disaster. We tried to put a pump in the chest, we would put it down the arm, we would transplant the arm on the pig, and then we'd try to perfuse it. And the pig would rip the tube out, and would break the tube, and the pump wouldn't work, and it didn't go anywhere. So John Jones, who was in Louisville, he's now a transplant surgeon in Tennessee, he said, look, we don't have the right control. We don't have pigs that we're transplanting and giving routine immunosuppression. Now, this was the turning point in my career. I said, why? It doesn't work. Look at the non-human primates. We know it doesn't work. Just to waste the money is going to cost me $70,000 worth of research to do 6 or 8, pigs. He said, no, we got to do it. We got to have that control. So, luckily, I listened to him. And, of course, it was the pigs on routine levels of human immunosuppression would keep the arm on. Now, I came that close to missing it completely. Now, these are the things you can't put in your biosketch, you see, because it brings you down to the kind of real life. So anyway, this is how we constructed it. It was a portion of the leg. We would dissect it out. This became the pig model, and we published all this prior to going to the first hand transplant. And if you gave routine immunosuppression and ran at 258 nanograms per mil, it stayed on, and if you didn't, it rejected. And there we see we're taking our biopsies. And there's a little piglet. There he's walking around with is the leg in front here. That's the partially transplant. So we did about 30 pigs, and we did them in different groups of cyclosporin in that pig and published. And I really owe in many ways my career to John Jones for not letting me go down the wrong path and insisting on that control group. So, and it was we were using the same. So skin is so allogenic, but we were able to use the same level of immunosuppression that you use to try to keep a kidney transplant and pig. It really was right in front of our eyes again that skin is not the major problem. So it became the first successful model, and it's back to the question. I'll just skip that. So a debate started at this point in the nation also did something else that was very controversial, and that started the debate. So we linked up with the University of Chicago and the ethics department there, Siegler, and I can summarize it this simply. We tried to change the paradigm of ethical progression to a new surgical procedure. So the old paradigm was you did the research, you did the transplant, then you announced it. We decided to reverse that paradigm at Siegler's advice. And so we did the research, then we announced we were going to do it. So the world could criticize us before we did it. And then did it. Now, if you think about it, that's totally logical. We don't let someone go clone human being somewhere in a lab here in San Antonio, and they come up and say, guess what? I've got twins here for you that I just did without checking with somebody. So that the pluralistic debate that's necessary in a free society, we got right up in front. Now, what happened was we got criticized that we were shooting our mouths off before we did something. But I, to this day, still believe that's the way we should approach these problems within science. So we announced it. We published 14 articles in Transplantation. We had a national meeting where we invited people from around the world. And the big debate at that time was what best mimics man, because a lot of my critics said that we should be doing non-human primates. I argued that the pig was better, but that was one of the big arguments. And I still, to this day, I say, look, if you do it in the pig and it works, excuse me, if you do it in a non-human primate and it works, it's most likely for sure going to work with man. But if it works in the pig and not a non-human primate, you still have to go to the human because the pig is a better predictor. And so doing a non-human primate is a waste of time and money. Now, it depends on what you're trying to look at, but in terms of transplanting the tissue, I'm convinced of that. So, other things, there may be reasons for non-human primates. Okay. I'll just skip that. So, we did the first transplant. It was the first successful. Now, the first hand transplant was attempted in 1964 in Ecuador. It lasted 2 weeks. The second transplant was attempted in France. It was done by my nemesis, Dubenard, who I like a lot. But he beat me by 3 or 4 months. He didn't do any announcement. He took a guy who was in jail and just gotten out in Australia, flew him to but this is the French. You gotta love it, And I'm very tied to the French. I mean, I was introduced to my wife by a French businessman who was very successful, who I met in the south of France 20 years before, who stole my girlfriend who I skied with. He became my best friend. So if you follow that little story. And he introduced me to my wife 20 years later. But I love the French, but they think different. And so this guy never should have been transplanted. His hand never moved, but he did he claims the first successful hand transplant. The hand never moved, never had feelings, there's no video of it working, and it was amputated at 26 months. 3 months, 4 months later, I did Matt Scott. This is Matt Scott, and that was in Newsweek. And there he is there we're getting the donor. I mean, you understand. Think kidney, think liver, it's all the same, except we're doing tendons, arteries. All this is standard. Any good micro-reconstructive surgeon can put a hand on it. I mean, it's hours, it's 8 to 15 hours in the operating room. You better have a bunch of people lined up. Now, I want to make this run. This is a video. How do I know how I do it? Can I do it from here?
That I cannot say.
I bet you I can. Here we go. Now, what you need to understand, because you're not hand surgeons, is the muscles, the fine muscles that make the hand move well are in the hand. So it requires innervation. I would argue that if you saw this guy walking down the street doing this, unless you look very closely, you wouldn't know that he had a hand transplant. He's using his thumb intrinsic muscles in order to get the opposition that's necessary. Now, if you watch carefully, you see that it's not a perfect hand because he fails in a few cases. Now, I also will tell you this is one of the best results you're going to get. You always show your best. Now, I've got other videos to show you the difference, but I don't have the time right now. But see what he's doing? He's cheating. He couldn't. You know how hard that is when you try to bring the quarter up? You got to have long fingernails or something to make it happen. But look, he's got a functional hand. It's weak. That's what we can produce, and unfortunately, we haven't changed much since that. He's probably one of the most successful, and the problem is that the immunosuppression is significant. This is the first time, and why we get so much criticism, we're not extending life, we're shortening it with a hand transplant. We collectively shorten life. So where are we now? Where are we 16 years later? So this is where we get into the statistics, and this article will be coming out in January on plastic and reconstructive surgery. So I have these weird hobbies in life. So I've never taken a statistics course my whole life, but I read statistics just for fun. Also, because it fascinates me how little we know as surgeons. So have any of you ever heard of non-parametric and parametric statistics? Anyone in the audience? Anybody? One person, that's good. So, it turns out that all the statistics I was taught using p-values and all of this is based on the premise that the standard deviation is the same in the two groups you're looking at, which is ridiculous. If I'm looking at hypertension study in Tucson, you wouldn't expect it to be the same as looking at hypertension in Hong Kong. Okay? The standard deviation most likely is not going to be the same in two groups, but we never look at it. We assume that as part of the package. When you go to non-parametric statistics, you don't have to do that. And also, if you have a very small group that represents the whole world, so you can't get the whole world hypertension. It'd be impossible. But with hand transplants, there's only 102 hands that have been transplanted on 80 patients. I can literally get the whole world. And then I can use non-parametric analysis to take that very small group and expand it. And I know this sounds loony, but you can do it. And it's because it's the whole world. And so I was able to take those 80 patients and expand them to the equivalent of 5,000 or 6,000 patients in terms of the bimodal distribution. And then I could use that to compare validly to the number of kidney transplants or the number of liver transplants to look at the differences between chronic rejection. So that's all kind of fast. It sounds, when you tell most people, they say, oh, you can do it. We actually spoke with Efron, who was a Stanford and the father of this type of concept. And actually, this concept has been around since 1971. We learn very slowly. So the data you're going to see, and I'll make the distinction when I had to use sometimes parametric as opposed to non-parametric. But this was looking at the data, doing it with a parametric analysis. So the 93% allograft survival, 68 months, and 48 was the mean. But if you looked at the complications and everything, we've made no advancements. In 16 years, none. So what I mean there is we still had acute rejection, we still had chronic rejection, and we still had complications. We could see them happening, but we hadn't changed the prevalence or incidence of any of that at all in 16 years. Because immunosuppression shortens your life, we had very few people who were enrolled. And because we had very few people who were enrolled, it became a very limited field. As a matter of fact, I would argue that composite tissue allotransplantation is the slowest start of any transplant that's been done. Now, obviously, you go right back to Murray in 54, I think it was 56. You know, it was probably slower, but certainly within the modern era, started in the 70s. You know, things took off faster than hand transplant. We reached our limit from the beginning because of the danger of immunosuppression from non-life extending transplant. This is a picture of the overall world of what's happened, and it's a little complicated, but it also shows you why there's a problem getting around the data. So the big pink circle represents all of those who have had hand transplants. But there are people who have had face transplants with hand and without hand. And then there are subgroups within that, looking at the Chinese experience versus looking at hand transplant with face or face transplant without hands. So that, and then the numbers down below show the number of patients, and this is going to be part of the publication. You're going to have to read the publication to break down the code. But what I want to show you is that even though I keep talking about hand transplant, the field is spread out. Uterus has been transplanted and a baby born. And they're now talking about putting a uterus into a man so the man can have the baby so the wife, for medical reasons, doesn't have to go through it. That's coming out of Sweden. Okay? Knee has been transplanted. And that's why I'm trying to tell you this world is going to explode when the immunosuppression is reduced. And the most common transplant done will be composite tissue. Not kidney, not liver, not heart. And whoever doesn't adjust to that economically and conceptually ahead of time loses. I jumped ahead on that, but that's kind of the take-home message I'm heading to. So I broke the world down into cohorts, and then using, when appropriate, parametric and non-parametric analysis to look at the data. And then when you look at this data, then I'm going to ask you a question. So if I looked at all the hand transplants that were done, so if a patient had hand transplants with leg, hand transplants with face, single hand, double hand, if you had a hand transplant, he was in that cohort. And that was in the whole world, the survival was 79%. If I looked at only people who had hand transplants, plus face, so hands, one hand, two hands with face, one hand with face, that combination, it jumped up to 84%, and that difference was statistically significantly different. And then if I took just hand transplant in Europe and North America, the data jumped up to 92%. But if I looked at China and Mexico isolated on their own, it dropped to 53%. Same world, we live in a completely different world than in 99. We have rapid communication, we're all at the same meetings now. Why this difference?
What's the definition of allograft survival?
In this particular table here, allograft survival is that you got off the table and when you lost your hand. So if you got off the table by 24 hours and then you lost your hand, you lost a hand in one day. Okay, if you died on the table and there was a patient who died on the table, it didn't count. Okay, but you had to be off the table. Okay, so let's dig into this a little bit. If you look at the total world of face transplants, very high survival, but a difference again if they were done in combination with hands versus just face alone. The bottom is face alone. And then, if you break out face with bilateral hand, only 17% of the allografts survive. Now, the numbers are small, so they're not statistically valid at this level. If you look at multiple extremities, so there were people who tried to transplant one hand, two legs, two hands. They all died. And I'm not talking about the allograft dying. The patients died. Clean sweep. And then the Pittsburgh protocol was just kind of a Starzl, give them bone marrow. Their results weren't as good as just leaving the bone marrow out, but better than the others. And then knee transplant, all of them lost their knees. None of them died, but all of them lost the allograft. Now, why when I transplant a hand, not one wrist has been lost, and yet all the knees that were transplanted, they lost their knee. Now, I have answers for all of these. So, and we'll come back as we sort through these answers. Risk still remains a huge problem because we can't increase our numbers. Why the variation in allograft survival? my theory is the following, and this is extremely important for understanding the field and where we're going. The risk of immunosuppression complications are significant, and therefore this should limit enrollment, but it shouldn't change the data outcome. If we're all approaching this the same way, yes, there's limited enrollment, but we shouldn't have a difference in outcome. So why are these differences in outcome? There's a perverse incentive, in my opinion, to take on more risk. Why? So you're sitting at Harvard and you want to push this field forward. Well, you can't get more people to enroll because electively, so you go to some person who's missing both arms and both legs and a face or some combination, and you convince them, because you're the doctor, you're God, that you should try this. And they buy on, and then they die. Now, I'm not criticizing those people, but I am saying we need to be realistic about what the probability of survival is when you start these large, multiple, and what the incentive is. The incentive is the economy of fame. You know what the economy of fame is? The economy of fame is like dollar bills in fame. I mean, I became world famous overnight by doing a hand transplant. I was in every newspaper in the world. There's a value to that. It's not like I can go, do it in the store, but that value will stick with me till I go in my grave. I'll probably put hand transplant king or something on that gravestone. So there is a real economy of fame that drives us forward and makes us sometimes make mistakes. There was also not great regulation. People in Turkey were doing whatever they wanted. So it's a real problem we're in now, is we can't seem to move forward because of the immunosuppression risk, and yet we have a lot of wildness going on in the frontier. And I want to say something that I'm a big believer in. I believe in Hayek, won the Nobel Prize in 1972 for, he was an economist who came from the Austrian school. He wrote there's 100 selected papers. It's the most influential papers of the 20th century. Einstein's there, the theory of relativity, and Hayek is there, on a paper that's called Information in Society. And basically what he says is we communicate by having a pluralistic society that debates issues. And when you stop that, you get a worse result than when you allow it. So the example that I actually put in the paper that's going to be published is abortion. Now, I'm not going to take any sides on abortion, but if you look at the statistics, abortion used to be considered by 60% of the population as being ethical, and it's now about 45 or 50% of the population. It's below 50%. So society changes, and it changes by discussion and by writing articles, and that's the way we should change within science. I don't believe in having a central organization saying this is how it should be. So standard of care, what should be done is a debate amongst knowledgeable people. And what we need to do is to use that approach and figure out some way how we can reduce the risk and control people who are doing things that are probably getting a little out of hand. So, let me look at my time and I'm going to get to the punchline. Briefly, just to give you a flavor of some of the stuff that's gone on, face transplant cohort, a patient who was HIV positive. He had had an oral tumor that had been resected a couple years before and he had a face transplant. Now look, if you need a liver and you're going to die, I understand it, but you're not going to die because you don't have a face. You just look bad. And then they transplanted him. Of course, the tumor recurred and he ended up dying. There was another case, and this was in the United States, where a patient was transplanted from a donor that was septic to a recipient who was septic for a face. And when I challenged that individual at one of the meetings, he said, well, I spoke to my transplant surgeons and they told me it was okay. Well, of course, you're saving lives. You can't wait for another donor to come along to get it perfect. And these guys, when I say they were septic, they were on antibiotics, but they had diagnosis of sepsis that was controlled. And you do that. That's what you're supposed to do when you're trying to extend a life. They could have waited for another donor. And then they tried to pull the same thing off in another case, and the patient ended up losing, you probably saw that one, the surgeon got up and cried on national television. The patient lost, one was eaten by the baboon, ring a bell. So when they transplanted her face and her hand, she went septic within hours. She had an abscess in her face. And she lost both hands. She survived. The face got through, but she blew out her hands. So, and in reality, in that case, I'm not sure they had options. I mean, after you take the face off and find an abscess, what do you do? You go back. It's kind of hard to go back. But these are some of the problems that we deal with. Let's go to chronic rejection, because guess what? We see chronic rejection in composite tissue. It comes on late. It comes as intimal hyperplasia. It does not seem to be related to acute rejection. We have more acute rejection than the other organs, and we have less chronic rejection. And here's once again where I use the non-parametric analysis, because I went to the SRTR, SRTR data, and I used that data and then used our patients and expanded them, using bootstrapping. Bootstrapping is something that exists within non-parametric. We can expand the numbers to get the mean. And when I compared it, we have the lowest rate of chronic rejection. Now, sitting within that is something that would be very useful to understand for the other organs. I don't know why that is, but statistically, we have less chronic rejection, and everyone predicted we'd have more. So, present problems, and then I'll finish this. We need to decrease in immunosuppression. We need to deal with the perverse incentive economy of fame. We need to figure out how to stop chronic rejection. We need insurance coverage, and we need standard of care definitions, particularly insurance coverage and standard of care. Hand transplant is still not covered by insurance. It's a struggle. It's a huge struggle. Most of the patients I did in Louisville, all the patients I did in Louisville, we had to pay $300,000 for the first 6 months in coverage, and then the insurance company would kick in. That's a negotiation you can do. And if we can decrease, and this is key, this is the seminal statement you need to keep in your mind. If you're looking where to invest your money going forward, keep this in mind. The first company that gets on the NASDAQ with the drug that achieves this for composite tissue will go to the ceiling. We need to decrease immunosuppression to increase enrollment. So, what you probably don't know now is that there are 2 drugs out there in small animal models that have gotten long-term success, and by long-term I mean a month or 2 months when they electively were sacrificed. There's a mouse model out of Yale with a skin graft, and carp out of Harvard with a gel and a rat hind. That has now been translated, and I can't talk much about it, or I have to shoot you, into large animals. There's teams out there actively trying to push this forward. If we were able to achieve this, then all of these would be transplantable. There's a project with about 12 different universities going on right now to try to do either. We don't really know sometimes what's going on until you start speaking with people and pushing into it. So here's where I'm going to end it, and I want you to think of this. I started this by telling you solid organ transplantation will not be the predominant transplant, right? If a brain-dead donor is brought in, and I kind of made these numbers up, but you're probably going to get 8 different tissues, or maybe 10. You can get 2 kidneys to different people, you steal the lungs, you take the heart, you can take the pancreas, intestine, but that's about it. But for composite tissue, you've got 2 ankles, 2 knees, 2 elbows, 2 shoulders, you've got skin, you've got radial nerve, ulnar nerve, median nerve, you've got brachial plexus, you have all the arteries. The number of composite tissues for sale, think economically now, is much higher than solid organ. So if we can solve the problem, what's going to happen is the generation of economic flow of a low estimate of 5 billion to a high estimate of 55 billion. Now, I wouldn't buy stock on this. I did these calculations myself. I'm not an economist. I did it with a medical student who has had his business degree, but you get the picture. So it's not about hand transplant. It's about changing the nature